Capillary refill time in clinical assessment of peripheral tissue. Perfusion, a detailed overview. Welcome to Medical Specialists Associates educational series on critical care topics. Hello, I'm Christopher Voss, MD, a board-certified critical care and neurocritical care physician. Today, we'll delve into the critical role of capillary refill time, CRT, in assessing peripheral tissue perfusion, particularly in the context of septic shock. Sepsis is a leading cause of morbidity and mortality in the ICU. Despite restoration of macrohemodynamic parameters, microcirculatory dysfunction can persist, leading to organ failure. Assessing peripheral tissue perfusion is crucial for identifying and managing these microcirculatory alterations. CRT measures the time required for the skin to return to its baseline color after applying pressure. Typically measured at the fingertip, CRT is a simple, non-invasive bedside tool that provides valuable information about microcirculatory status and skin perfusion. To measure CRT, apply firm pressure to the soft tissue of the fingertip for 5 seconds. Release the pressure and observe the time it takes for the skin to return to its normal color. A CRT of less than 2 seconds is considered normal, while prolonged CRT indicates impaired peripheral perfusion. CRT is a useful parameter in the initial assessment and ongoing monitoring of patients with septic shock. It correlates with other clinical signs of perfusion such as skin temperature, color, and mottling. Prolonged CRT is associated with higher lactate levels, indicating poor perfusion and greater severity of illness. A study by Etufela et al. Demonstrated that a prolonged CRT in 4.5 seconds is predictive of 14-day mortality in septic shock patients, with higher sensitivity and specificity when measured at the knee compared to the fingertip. Another study by Hernandez et al. Found that CRT was a better predictor of mortality compared to serum lactate levels. Integrating CRT into the management of septic shock can guide resuscitation efforts. Early goal-directed therapy using CRT as a target can help optimize fluid administration, vasopressor use, and overall hemodynamic support, improving patient outcomes. When using CRT in clinical practice, consider the following. Standardization. Ensure consistent pressure and duration during measurement. Inter-rater variability. Train healthcare providers to minimize variability. Complementary assessment. Use CRT in conjunction with other clinical parameters, such as lactate levels, skin temperature gradients, and mottling scores. Following CRT-guided resuscitation strategies can lead to several beneficial outcomes. Reduced mortality. Early identification and correction of perfusion deficits can decrease mortality rates in septic shock patients. Improved organ function. Optimizing tissue perfusion helps prevent organ dysfunction. Shorter ICU stay. Effective resuscitation can reduce the duration of ICU stays and the need for prolonged mechanical ventilation. Better long-term outcomes. Preventing microcirculatory dysfunction improves overall recovery and long-term quality of life. Recent research continues to validate the use of CRT in critical care settings. The Andromeda Shock trial, for example, compared resuscitation strategies targeting CRT versus lactate clearance, showing that CRT-guided therapy led to less organ dysfunction at day 3 and a trend towards reduced 28-day mortality. In conclusion, CRT is a valuable tool for assessing peripheral tissue perfusion and guiding resuscitation in septic shock. By incorporating CRT into clinical practice, we can improve patient outcomes through better targeted interventions and ongoing monitoring of microcirculatory status.